The keys to sexual health, coming next on Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. Biologically, the primary function of any living thing is to make more living things. In other words, reproduce. Whether it's a pine tree, a prairie dog, or a person, the overall balance of our well-being is impacted by our sexual health. Our physical health, in turn, impacts our sexual health. Although sex seems to be everywhere in our society, on our advertising screens, everywhere, we seldom talk about how to maintain it in a healthful manner throughout our lives. We start with the Prairie Doc quiz question about a sexually transmitted disease. Is it true or false? Here it is. Over 50% of the people in the U.S. who have HIV are greater than 50 years old. True or false? Tonight I'm joined in the Yeager Media Center studio on SDSU campus by Dr. Donna Sweet from the Wichita Internal Medicine Midtown. Donna? And via Skype from Austin, Texas, we are joined by Dr. Jill Grimes, family physician and author. Donna, tell me a little bit about where you came from and why the heck you're here.
Well, I'm here because I take care of about 1,250 or 1,000 HIV patients in Wichita, Kansas, and most people are amazed that we have anywhere near that amount of HIV in what most people consider rural America, although we're pretty urban compared to up here.
Okay. Yeah.
I grew up on a farm in Kansas. I'm pretty much stayed where I grew up. I'm a general internist, and I got involved in 1983 when people were starting to come back to Wichita with things like Kaposi sarcoma and pneumocystis, and they weren't treated very well. Anybody old enough to remember the early days of HIV know that the stigma and the discrimination and the truly horrendous treatment of this patient population was awful. So I got brought in by an HIV infected, at that time we didn't know it was HIV, but he had Kaposi's, was treated poorly, and I started trying to do some education around his disease so that he was treated better. From that, it's now evolved to the Midtown Clinic, which takes care of the bulk of HIV disease in Kansas, both rural as well as the city, because I do outreach clinics into western and eastern Kansas so that people don't have to drive. So that's how I got here.
And you come up and share us information. Has the demographic of HIV from those beginning years changed till now?
Tremendously in terms of age. People still get infected at a young age, but what's different is 1983 I could certify everybody for hospice because if they had an AIDS diagnosis they were going to be dead in 6 months. Now, fast forward 30 years with the medicines we have, if people are smart enough to get tested and get into care, they will have the same length of life as an age-matched control. They don't have to lose any of their longevity if they get into care.
Early enough.
Early enough. And consequently, we're still seeing new infections, and new infections in the sexually active older person. I'm not going to say elderly, but the people that are older. And people don't die. We've decreased the mortality by almost 90%. So we have new infections in the older population, and our young population is aging into the over 50 population.
Right, and you have come to our South Dakota ACP, American College of Physician Internal Medicine meeting every year since I was born, I think.
Not quite, but close. And
one of our most important guests, wonderful lecturer, you know, you're known worldwide by your expertise in HIV. I'm so honored to have you on the show, and thank you for being here, and a dear friend for many years.
Thank you
so
for
much.
having me.
And Jill, you and I have been friends for a couple 3-4 years since you and I were at a same meeting, and you had written a book, and I was asked to review that book for a publication. Tell us about your book.
All right. Well, actually, I think it's been about 8 years that we've been friends.
Is that right?
Yes, because that was at a media conference before my first book ever came out. So what makes this book different is that it's stories. Because what I found as a primary care physician in private practice is that virtually everybody that I diagnosed with a sexually transmitted infection was surprised about it. And I wasn't terribly surprised because they were being sexually intimate, but they were very surprised because just as Dr. Sweet was saying, they didn't think that kind of disease happened in this kind of people. And so I really wanted to find a different way to educate people about it, and particularly young people. So my book is called Seductive Delusions, and it shares stories of people as they're diagnosed with different sexually transmitted infections. And then there's a kind of a Q&A, frequently asked questions at the end of each section, so they can get all of the medical information in one spot. And it's actually been used in high schools in San Antonio for about 5 years now, and the teachers and the kids love it.
And I loved it. It was a wonderful approach to it, because you also put in there what people were thinking when the physician or the provider was talking to them and trying to explain this. And those thoughts are so often what they believed, and it had so little to do with factual information that I was fascinated by the thought process. You did a wonderful job of describing how people behave.
Yeah, I particularly liked the story form, because I believe that stories makes everything work. I mean, communication is not as good as it could be, and stories really, and almost always, until you get a story there, and then you can live and walk in the moccasins of the person who is there. And so I loved the book, and my recommendation was that every high school should be using that book as a textbook for health education. And you say that there's a number of high schools that do use your book, don't they?
Yes. I guess there's about 8 high schools in San Antonio. It's one school district that adopted it 5 years ago. And it's really funny. The comments that the kids make are hilarious. Each year I go down there and I speak to the kids and answer questions. And it's fun because one of them's in my old high school. And they'll say things like, yeah, is it weird that I was reading it like the Hunger Games? Because they really get into it. Yeah. And at first, it's the most read book that nobody wants to read. Because when you talk about reading a book about herpes or sexually transmitted infections, that doesn't sound interesting. But then they get into the stories, just like Grey's Anatomy or ER, any of the medical shows, the dramas that we all love to watch.
It makes it real, Jill. And the truth of the matter is, sexually transmitted infections are real, and the majority of them are asymptomatic. You were discussing for a bit about earlier pre-show about the 50-year-old person. The majority of people who have HIV are older than 50. How does that go?
Well, people get infected at an older age. People don't stop having sex because they're 45 or 50, much to our young people's disbelief. So people can still transmit it, and people are aging into it. Those that got it at 20 or 30 or 40 aren't dying. It's a long-term chronic illness, so it's still out there.
So more than 50% of the people who have HIV are older than 50 years of age.
True.
And the majority of them are asymptomatic.
True, and especially if they're on medication. They are not only asymptomatic, they are non-infective. And that's one of the reasons you asked me earlier, what was my passion? Why do I do this? Why do I come to South Dakota and go to Russia and all the places I've been? Everybody needs a test. Everybody needs to know their status, because just as in Jill's book, she points out that nobody thinks it can happen to them. People can carry this virus for 10, 12, 15 years with no symptoms. Most people don't remember whatever it might have been that got it for them. It can be sometimes inconsequential, they think. So everybody needs to know for sure. It's a simple test. It's 99.
So you're not giving it away as a gift, a bad gift.
Right. It's 99.9% sensitive and specific. It's relatively inexpensive, and everybody deserves to know. And the guidelines have said we should have everybody tested since 2006.
So, yeah, we are not doing it though, are we?
We're not, no.
Now, let me ask you this. Of all the people who have HIV, which means before they get the full-blown AIDS, which is, HIV is the infection, but you don't know it many, many times, what percentage of those people who have HIV don't know they have it?
Right now, it's probably 16 to 18%. So it's come down a lot since we started doing the testing. It was 25% in 2010 or so. So we've made some progress, but it's slow going. And back to Jill's book, I was very fascinated by the herpes discussion because that is so amazing to me. People are much more upset about a herpes diagnosis than they are about syphilis sometimes. And I think that's more the stigma and the sort of discriminatory approach to it, much like HIV. And it's a long-term chronic virus. But I was really taken by how Jill captured that in the people that had herpes. It was the worst thing that could ever happen in their life. And that's, you know, it's bad, but it's probably not the worst one you can get.
Not a real bad deal.
Yeah.
Well, we'll talk about it a little bit more and get back to Jill on herpes. But we should also talk about happy, good things about sexuality, not necessarily the infections, but it's important to be safe while sexually active at all ages. South Dakota State University has multiple programs designed to keep its students healthy.
HERO is a health promotion organization, stands for Helping Everyone Reach Optimal Health, and the group is broken up into 4 different committees, and one of the committees is a sexual health committee. It's very new, we just started it last year, and so this past year they really focused on large-scale programming on campus. So they helped put on the sex ed boot camp that we had in the fall, as well as 2 other alcohol, sexual assault programs that we put on in the spring. They kind of help coordinate that, promote it on campus, and try to get the word out to their peers. I think they make it fun and they make it non-threatening when they're doing their programs. We open it to everybody, you know, it's nothing that's required, and I think, you know, handing out condoms on Main Street at the Union, it's happened with a lot of different groups now, so I don't think students are really surprised by it anymore. And we have, you know, condom dispensers in a majority of the bathrooms on campus, so I don't think it's anything new, but no, we don't hear a lot of backlash.
On campus, we typically see students become more concerned after certain events like Hopo Days or Christmas break or spring break. I can't say for sure that the rates are increasing with those certain times, but people are definitely more aware of their behaviors after those specific times during the school year. A lot of times people aren't going to have any signs or symptoms when they have an STI. Most frequently, people will have like burning with urination or feel like they have a UTI, maybe discharge from the genitals or itching, those sorts of things going on. If someone recognizes those signs or symptoms, they should definitely call their provider and get an appointment to be seen as soon as they can. To avoid getting an STI, the best option is abstinence, not having intercourse at all. Next best would be condom use, consistent and correctly. Using them for every sexual act is another great way to prevent STIs.
I believe that knowledge is power, and so kind of giving students all of their resources and educating them to make those healthy decisions, that's kind of the role that I take. And I think communication is huge, so I think students need to be communicating with their partners and asking those questions before, you know, the sexual practices are taking place, so that it's not a, you know, what if after kind of thing.
I think the important thing is to be informed, not being naive about what's going on. We do have STIs in South Dakota. We do have STIs and HIV in South Dakota. So it's important just to be smart and protect yourself and know who you've been with and who they've been with. I think that's a big important thing for sexual health.
Those are important words, and of course we want to do what we can to prevent these illnesses because we're in favor of safe sex. Let's talk about prevention a little bit. Jill, what's your take on important preventive measures? Because people are going to have sex. We want them to.
Yes, we would stop, you know, reproducing.
That's right.
So it's an okay thing. Before we go to prevention, can I just jump back for 1 second
Sure.
on the diseases being silent? I want to make 2 points about that. Number one, really, people do not believe that they wouldn't know if they had a sexually transmitted infection. And so I'd like to just take a second and reinforce that. So for example, with chlamydia, which is the most common bacterial sexually transmitted infection, half of the time men who have it have no symptoms, and 3/4 of the time, 75% of the time, women do not know that they have it. Gonorrhea, it's lesser, but about 30% of women and 10% of men do not have symptoms. With the human papillomavirus, HPV, that's the one that causes both warts, genital warts, and cervical cancer. That's almost always silent. HIV, we just were talking about that. It's down to about 10%, you said, Donna, is that right?
True.
Right.
That people have it, but they don't know it. And herpes, again, very, very common that people don't know it. So the only way you can know is to get tested. And so we're just going to keep saying that over and over during the show. Please get tested.
It's so very important for women too to understand if the chlamydia and gonorrhea goes untreated, they can end up infertile. It's one of the leading reasons for couples when they do decide they want children, they can't because the tubes have been scarred from these infections that they never knew about. So getting yourself checked and making sure that you let your provider know that it's a possibility.
So if you're a guy or a gal, and your age doesn't matter, you go into your doctor and you say, "This is private, check me." I had a guy do this within the last month. And he said, "I've been checked already a couple months ago. I'm worried. I'd rather not worry." And I said, "I'm with you." And we checked him. I think it's a simple way of solving the problem. Go into your physician or your clinic or your public health place and have yourself checked.
And especially for young women, I think realizing that HPV is a sexually transmitted disease. I think many young people don't understand that, and the reason we do pap smears is to find it before it causes cervical cancer. So a young woman should not be upset if a provider says, "Well, since you're here, we need to check for chlamydia, we need to make sure you don't have any HIV, we're going to check for all the gamut of things that you can pick up as a result of sexual activity."
Right. Jill, your comments as well about prevention, your comments as a physician, do they come to you and talk to you enough about this?
Yes, but I still have one more thing to say about the last part, if you don't mind.
Sure.
So testing doesn't always even involve a physical exam. I'm not encouraging that because I still am in favor of doing a physical exam along with it because there are things that we can see on the exam. But for people who just want to get tested, a simple blood test for HIV and a urine test for gonorrhea and chlamydia frequently, is all that you need. And the other thing I want to say before I go into prevention, which is super important, but is that one of the things that happens is people will have a new partner. They might have symptoms for a day or two, perhaps itching, burning, even discharge, but because that goes away after a day or two, they're convinced, that definitely was not a sexually transmitted infection. Maybe if it's a woman, they might think they have a yeast infection. But no, just because you have symptoms and they go away does not mean it was definitely not a sexually transmitted infection. So again, if you've been sexually intimate with someone, and that can be just with oral genital intimacy, so oral sex, or anal sex, or regular vaginal penetration, any of that, you should get tested. Okay, now we'll move on to prevention.
Yeah, let's hear those words. Except, so if you're a man who has sex with men or a woman who has sex with women, are there any particular special precautions one should take?
Same precautions as heterosexual, although in men who have sex with men, it's more likely if one has hepatitis C that they will spread it. Hepatitis C is not very often spread with heterosexual contact, male, female. But no, the prevention methodologies are the same for both. They just have to be used each and every time.
Right, and we're talking condoms.
Condoms, yes.
Or barriers.
Or barriers. We're
right.
talking barriers.
Right.
It's interesting you bring up women who have sex with women. They certainly are able to transmit the infections like herpes and others, but quite frankly, HIV and Hep C has not been an issue for the most part in the female gay couple. Much less so than it is in men who have sex with men.
And that has to do with probably the anal involvement.
Exactly.
Jill, you were going to say some words about prevention.
All right, so the good news in sexually transmitted infections these days is that we have fabulous protection now against the human papillomavirus. And again, that's HPV, not to be confused with HIV. HPV, human papillomavirus, is what causes genital warts as well as a number of cancers, including cervical cancer. It can also cause cancers of the vulva, vagina, or penis, or anus. And in fact, we're up to over 33,000 cancers per year caused by HPV. So it's really important for people to know about the HPV vaccines. And the one that is most often used in the United States is Gardasil. That's the quadrivalent vaccine. So it works against 4 strains of HPV. And it is for both boys and girls. Let me say that again. It is not just for women. No, guys do not develop cervical cancer, but they certainly develop genital warts, and they also can develop anal cancer or penile cancer. So it is for both sexes.
And they carry it.
And nasopharyngeal.
And
We're
nasopharyngeal
seeing
cancer.
increasing head and neck
Yes.
cancer that's HPV related.
But the timing is the most important thing about this vaccine, right? When should somebody have the HPV virus Gardasil vaccine?
It's most effective before you become sexually active because there's such a high percentage of
People who do have it.
who do have it, and your likelihood of picking it up early on in your sexual life is high. So we really need to start, I think, isn't it, Jill, 11 years old when most are
Yes.
recommending the first shot? It's a series of 3. It's important that you get all 3. That makes it the most protective.
How early could you start it?
10 or 11,
So 10 to 13.
10 to 13.
So, is it covered by insurance?
For the most part, yes.
And it costs, if, well, you don't care if the insurance is covering it, but if they don't cover it, how about a public health?
You can get this vaccine at most public health departments. At least in my own community, it's means tested, meaning if you don't have the money, they will discount it, and there's ways of getting it.
Okay. Jill?
Well, I was going to comment, it is an expensive vaccine, relatively speaking. If you were paying cash for it, it can be up to $150 per injection, and there are 3 injections. However, if you ask anyone who has genital warts, or certainly one of the HPV-related cancers, that's a drop in the bucket compared to that. And right now, the vast majority of insurance companies are covering it.
So our 3 boys and our daughter have had that vaccine, and that's an important issue because it will prevent them from having that kind of cancer that's a result of that kind of wart. I expect that they will have sex at one time in their life, and that's an important thing. And we want people to have that opportunity as they get older. We're not against that, but we would like to have no infection. What percentage of people out there now have that are of age have HPV? Do we have it something like 70% or some?
75%, I think. Jill?
I mean, there's 20 million Americans currently infected with HPV, kind of all the time. But the vast majority of HPV does resolve on its own. We're giving this vaccine for the small minority, but still large numbers of people where the HPV your body doesn't get rid of it. And so when it stays for a long time, that's when it becomes a problem for causing cancers.
Right.
And it's thought that in a lifetime, if you're sexually active, you have like an 80 to 85% chance of contracting HPV at some point. So that's
80
why
to 85%.
At least 3 out of 4. I mean.
So, of course, there are people who the argument has been, well, that's going to encourage my daughter or my son to have sexual activity. Do you think there's any truth to that comment?
No.
No. Absolutely not.
That's the easiest question you've asked,
Yeah.
because this whole risk mitigation issue is so misused. It's like saying, and we'll talk about HIV, because right now we have excellent ways of helping people not get HIV. It's called PrEP, pre-exposure prophylaxis. It's a medication that people at high risk can take every day, and if they are encountering HIV, they have a much reduced risk of getting it. There's a lot of pushback by some providers as well as groups of people that say that's just allowing bad boys to do more bad boy things. It's a very different, my approach is very differently. We're trying to get people through a period of their life where they're already doing things that are putting themselves at risk. I'm just trying to find some way to help them not pick up something that they're going to carry the rest of their life and have to deal with. It's not necessary, and the studies have shown it doesn't precipitate more bad sexual behavior. but they continue to do what they're already doing, which is putting themselves at risk. If we have tools, it's like birth control pills. Why would we not want to have a woman be able to control her reproductive destiny if we've got good ways of doing it?
All right. Yeah, my thought is that we have other issues to talk about, but I want to say a few things about sexual dysfunction and talk about, we have a population, some people might be out there that are 80, 90 years of age that might be interested in sexual function. There's a lot of things that keep people from being active sexually when they could be. And we're talking monogamy, we're talking partners that we love. Comments, I mean, there's new pills out, the pink pill for women, the blue pill for guys. What's your take, either one of you, on those particular medicines? Jill?
Sure. I'll address the new, Viagra for women. It's called Addyi, and I have no experience prescribing it yet because actually it's not available yet, and it will be next month through specified providers. And it's important to know a few things about this pill. It doesn't work the same as Viagra. Viagra worked directly with increasing blood flow to the penis, and so it helped directly in that manner. This one works more similar to how antidepressants work. It works on the neurotransmitters in your brain, and when some of those are low, we don't understand exactly how all of this works, but this one raises the dopamine and the adrenaline in your brain, and it leads to increased interest in sex. So if you are not having sex because you don't like your partner, because you're, having poor communication, or you're just overworked and overtired, taking this pill is not going to make you interested in sex. It's not for that. This is for someone who is in a happy, content relationship, but they just don't have any lust, any sex drive, and it is going to help with that. It's not going to be prescribed for anyone who drinks alcohol regularly because there's some interactions in the studies. Honestly, the main interactions were in the studies were in controlled settings where they gave people quite a bit of alcohol, and there was an increased incidence of passing out in people who drank alcohol and who were taking this pill regularly.
I didn't quite catch what you said. Increased incidence of
Passing out.
Fainting spells.
Yeah.
And so not unlike antidepressants or other medications, we're going to recommend that people do not drink while they are taking this pill regularly. However, the truth is, in these studies, there was a good percentage of the women who drank occasionally, socially, a glass of wine with dinner sort of thing, and they did fine. The FDA indication is to have no alcohol, just so that we're clear about that. But so that's what this new pill is about. It's to increase interest in sex for people who have low sex drive, but they're in positive, committed, or in positive relationships where there's not other reasons for them not to want to have sex.
Which is actually quite different than the blue pill, the Viagra for men, because it will not really, if you don't have a libido, if you're not interested in sex, just taking the blue pill won't change that. It may help you get an erection and have sex if you're interested, but I warn my men that it's not going to suddenly make them more lustful.
I would say that I prescribe a fair amount of this for the men that I care for, and I have a lot of older guys, and when they start passing the age of 60 or so, the function slows down, and it doesn't hurt them to have an opportunity to make sure that they can come through with the function that they're interested in. I have been lately using the generic Viagra in the 20 milligram tablet form. Generally, Viagra is 50 to 100 to get the function, and if you go with 20 milligrams and you to have them take 2 to 5 of them, depending upon what they need, an hour to 2 or 3 before their activity, it's a whale of a lot less expensive. I know Viagra is looking at giving the reduced cost samples kinds of thing, and Cialis has done the same, and so has Levitra. and they do work.
And Cialis has the added beauty of, if you use the 5 milligram and take it every day, if men have benign prostatic hypertrophy, trouble urinating and big prostate, they can actually get very good reduction in their BPH symptomatology and increase their erectile function.
Right, at the same time.
At the same time.
So and my sense is that instead of using the other pills that shrink the prostate and kill the sex, if I were having a problem with my flow, I would probably go with that thing that encourages the sex and improves the flow, although we don't really understand why it works on the flow. Jill, any other comments?
Yeah, well, I was going to go back to the female one, not necessarily the female Viagra equivalent or pseudo equivalent, but more something I see very, very commonly in postmenopausal women is that they're not interested in sex because it's become pretty uncomfortable for them. And with the studies that came out years ago where all the physicians switched from putting everybody on estrogen to pretty much taking everybody off of estrogen, there's need for more estrogen in the area. And the good news is that most of the time, the vast majority of women can tolerate just local estrogen that we put in cream form or a suppository form in the vagina a couple times a week, and that can make a world of difference for women.
And what kind of lubricant would you suggest for women? There are a variety of different kinds, and I don't think it really matters, does it?
No.
Just some kind of lubricant?
Yes.
Oil, you can buy it over the internet.
Well, water-based, if indeed you're going to
Yes.
use condoms for protection, because if you use oil-based, you will destroy the condom.
Destroy the
so
condom.
I recommend water-based lubricants, and then you just find the flavor and the smell of the one you like.
Okay. All right. Any other comments about that before we move on? We've got other, your book. Oh, well, we can jump into this first. Sexually transmitted infections are a serious problem, even in South Dakota. Our state epidemiologist, Dr. Lon Keitlinger, gives us an update on these diseases in our region.
Good evening, Dr. Holm and the viewers of the On Call show. I'm Lon Keitlinger. I'm the state epidemiologist with the South Dakota Department of Health, and I'm here in Pierre, and I'm giving you a quick public health update. With the infectious diseases, we have many diseases that are up now. Hepatitis C is also up in the state, and very disturbingly now we're experiencing a big increase in the STDs, or the sexually transmitted diseases, or as some people call them, the STIs, the sexually transmitted infections here in South Dakota. And these include gonorrhea, chlamydia, HIV/AIDS, and syphilis. For much of the 1990s and the 2000s, South Dakota was considered to be a low incidence state. We had the diseases, but at fairly low numbers, and some years we didn't have any syphilis at all in the state. But we're now becoming, I hate to say it, but we're on the track to becoming a high incidence state for these diseases. Chlamydia has been increasing every year after year in the state. We now have about 4,000 cases reported annually here in South Dakota, and many more cases that are undiagnosed, unknown, or unreported. Gonorrhea, in the past couple years since 2008, has tripled in South Dakota. And both chlamydia and gonorrhea, they cause all kinds of problems, including, unfortunately, infertility. HIV/AIDS is also up. Just last year, we had one of our highest years ever with 39 cases. And already this year, as of the end of March, we had 15 cases of HIV/AIDS already in the state. And very, very concerning is we now have outbreaks of syphilis in South Dakota, the likes that we haven't seen for 45 years in the state. So all physicians should have syphilis on their medical radar screens, and all sexually active people should be aware of the disease. They should know how to recognize the symptoms, and most importantly, they should know how to prevent it. And prevention measures include abstinence, monogamy, and condoms. Screening is also very, very important. Syphilis causes sores, it causes rash, it causes neurological problems, stillbirths, and congenital disease. So syphilis puts our babies at risk.
Thank you, Dr. Keitlinger. It's great to have a connection with the state epidemiologist who's willing to share with us those kinds of information at the drop of a hat. It's surprising that syphilis is on such a rise. Donna, I heard you give a lecture on syphilis a year ago this very month, and your comments about syphilis in Kansas, anything similar?
Well, we don't have the outbreak that you have here, but I have seen more syphilis in my clinical practice in the last 2 years than I saw in the first 20. It is on the rise, and it's one of those things that oftentimes goes unrecognized. People, the chancre, the sore of syphilis is painless. It can be hidden in the vulva, can be at the base of the penis, places where people don't really look, and it doesn't hurt.
It's a sore that doesn't hurt.
Doesn't hurt, and it goes away on its own. But then you're into secondary syphilis, and once you have secondary syphilis, the main symptom is a rash that can be on your palms and your soles. That's very pathognomonic of syphilis. So anybody that has a rash should get it checked out and realize that even if you don't get it treated, it will go away. And then it's in the system, and it's considered a latent disease, which can then
cause dementia.
And it can go into neurosyphilis, can cause dementia, it truly can cause blindness, it can cause neuropathy, it causes tremendous neurologic issues. So making sure that if you have had sexual activity that you mention to a physician that you probably need a syphilis test to make sure. It's like HIV. You can know and get it taken care of, or you can ignore it and get sick.
Taking care of it. It's not that hard to treat, is it?
No, a shot of penicillin really will take care of it. That's the good news about, as Jill said, chlamydia, gonorrhea, syphilis. You can get them treated and they're gone. So make sure you find out if you have them.
Are you seeing syphilis? I think we're having it because of the oil fields in this state in
Most people
North Dakota.
think that, yeah.
I don't know if there's any truth to that. Jill, are you seeing that in Texas?
Well, yes, we definitely have syphilis in Texas. I don't know the numbers for my county off the top of my head, but we definitely see it. The place that I have seen it the most in clinical practice is actually picked up on pregnancies. So we're treating it prenatally, which is great because we're catching it. And so all women who receive prenatal care definitely get screened for syphilis.
But not everybody gets prenatal care with their pregnancies. And so if you're pregnant or possibly pregnant, check it out. Go to your doctor and get the prenatal care stuff taken care of. Well, we haven't talked about herpes simplex. Cold sores on the mouth, but cold sores in the genital area. Let's talk a little bit about that. That's not as easily treated, but it's not as severe of an illness.
That's the way I view it. It's painful when it occurs, and it causes a lot of shaming and a lot of grief in relationships, but the truth is people can carry herpes for years and years and then have it break out. It does not necessarily mean your spouse or partner has been
exposed
is exposing you to something new. It may be that it's just never broken out. Jill, you talk a lot about it in your book, and I was really pleased with the way you described how to handle it.
Yeah, what's your take on that?
Well, it's really, really common. And one of the biggest misconceptions is that people think that cold sores, fever blisters, they'll say, oh, I don't have herpes, it's just a cold sore. And they may have been told that by a physician. They certainly may have been told that by a family member. But the reality is that the lesions that we see there, it's a great picture of one right there. So you see it's the little cluster of blisters, and there's a bright red base to it, and it's right there on the lip, on the outside of the lip. So these are not the little tiny shallow ulcers that we get in our mouths sometimes in the inside. This tends to be mostly on the outside. It can be right there where that picture shows on the lip. It can be up in here, along the nose, between the nose and the lips, or down here on the chin. And all of that is herpes. And most of that has been transmitted not through sexual means, but within families from kissing each other or sharing utensils, sharing cups. All of those things can pass it along. And, go ahead.
Grade school or preschool, I mean, that's when many of them get those herpes simplex of the mouth. Mm-hmm. So, and it can also occur and spread, that kind of a thing can spread down below if you're having
Yes.
oral sex.
Right. We talk about herpes 1 and 2. 1 is above the waist, 2 is below the waist, but there's nothing to prevent 1 from going to 2, especially in the scenario of oral sex. And that's again what people have to understand. Genital herpes is the same virus as oral herpes, as the cold sore.
Right. And in fact, the majority of the genital herpes cases that are diagnosed now are actually from type 1 herpes from oral sex.
Really?
Yes.
So, so it's not the end of the world.
No,
and
it's
of course, we don't have. Go ahead.
Sorry, just to say 1 in 5 Americans over the age of 14, if you do blood testing and look at antibodies so we can pick up the silent infections, 1 in 5 are infected. It's common.
And not the end of the world, not something to be shameful of, but I would, it just needs to be watched and controlled, and you can reduce the severity of the outbreaks with medications and so on.
Truly, if people have a lot of recurrences, which is the problem with herpes, you can take suppressive medications to keep that from occurring. Probably the biggest problem with herpes is, as a woman, you need to make sure you don't have any active lesions at the time of labor and delivery, because it could be passed to the fetus. So it is a reason sometimes for C-sections if there's an outbreak at the time of delivery.
Right, because if the child gets it into the brain, or, I mean, it can be a terrible thing.
Devastating illness.
So let's talk about chlamydia and GC. Gonorrhea and chlamydia. You said you can test for these by urine testing. Let's hear more about that, Jill.
So gonorrhea and chlamydia are the most common bacterial sexually transmitted infections. So because they're bacterial, the good news is we can give you antibiotics and completely cure them. However, we can cure the infection. If you have had the infection for years, there could be potential scarring that is not going to be undone by taking antibiotics. And it's that scarring that can lead to infertility. So we believe that if primary care physicians were all on board and we tested every sexually active young woman for chlamydia once a year, we would prevent over 40,000 cases of infertility per year. That's how important it is to get tested.
Important to reduce infertility. I mean, that's a devastating problem.
The other thing people somehow don't realize is just because you have it once and get it treated does not mean you can't get it again.
Right.
And we have a problem with people, women especially, will go to the doctor, get it treated. If their partner is not treated, they're going to get right back infected again. So it's truly important to make sure that somehow the partner in that relationship gets treated.
Okay.
Some places allow therapy, indirect therapy, in the sense that if I wrote the prescription for the woman, I could write another prescription for the man. It's not legal in all states. It's not legal yet in my state, although we're trying to get that done. I don't know if Texas allows that or not, but it's one of the things that would help us get rid of some of the recurrent disease.
Right.
Exactly. And it's one of those things that many physicians have worked around the system. Just like we use some drugs outside of FDA specific indications, there's certainly physicians who write for double the amount of antibiotic. But legally, we can't do that really anymore in this climate, because if you gave an antibiotic to somebody that's not your patient and they had a reaction to it, then you're setting yourself up for legal liability.
Yeah, I have to admit that I probably treat partners just when the guy comes in.
I didn't hear that.
You didn't hear it? I just kind of have a tendency to probably do that, probably. Let's talk about trichomonas. Now, that's something that I learned from your book, definitely. There's some things about that particular flagellite type of infection. What about that, Donna?
Well, what we've found is that trichomoniasis causes a particularly nasty inflammatory reaction in the vagina. Consequently, a woman who has trichomonas, if she is exposed to HIV disease, she is much more likely on any given encounter to be infected. HIV is one of those things, a lot of people get exposed to it and they don't become infected. But if you have trichomoniasis, you're much more likely. So consequently, we're recommending that, especially in women with HIV, that we watch for that closely and treat it aggressively so that we can, again, prevent spread. It's pretty benign. It causes a foul odor and itching, but in terms of the actual physical symptomatology for the woman, it's not horrible, but it does lead to a lot of inflammation.
And it's easily treated.
Easily treated.
Ed, do you screen for trich with just a wet prep?
It's a wet prep, and you look for the organism.
Any follow-up on trichomoniasis, Jill?
Yes, it's the most common infection that no one's ever heard of. Seriously, I wrote an article for Glamour magazine, of all places, because they were asking what do doctors miss, what do patients miss, and it's estimated by the CDC. The estimates haven't changed in a long time, but that we have over 7 million cases of trichomonas per year, and that's actually more than gonorrhea and chlamydia and syphilis put together, but no one's ever heard of it. And what I see a lot, when I started, honestly, I started looking for it more after I did research for my book. And I found it more and more and more and realized, oh my gosh, I've been missing this. And where I saw it the most was in women, particularly more mature women, who were having recurrent urinary tract infections, or at least symptoms of urinary tract infections. We were treating them because they would come in and they would be so sure, oh no, I've had this a million times, I have it again, and I've got burning and itching, and and I know what this is, and we would do a urine culture and it would be negative. But if, as the physician or the provider, if you don't look at that wet prep right away, it's very easy to miss this organism because it's the same size and shape as a white blood cell, which we frequently have in our urine.
So what do you treat your patients with trichomonas?
I'm sorry,
what treatment do you generally provide?
Metronidazole.
Metronidazole, topical?
No, it's oral. You can
just an oral tablet.
You can take it for a week, or you can take a big dose one time and get it over with. You have to be careful with flagyl metronidazole. You can't use alcohol with it, or you can get deathly ill.
Yeah, it has an antabuse kind of a reaction.
Antabuse effect.
Right.
Yes. Yes,
So,
clinically, I wonder how often that happens. It's kind of interesting. I'm now currently practicing in a college population where giving them something where they can't drink is not, the recommendations are not always followed. So it's sort of interesting. So I do not give the big dose altogether because I've had 2 high incidents of nausea and vomiting from that. But again, some of that might be my population.
So we've got 2 minutes left of our show, and we haven't talked about hepatitis C. I think we should venture into that particular topic because that is also something that's spread, you said more often with men having sex with men, but other ways.
It's truly an STI, but the bulk of hepatitis C is transmitted through blood products in injection drug use, sharing needles, tattooing, piercings, things where there could be contamination of a material with somebody else's blood that has hep C. But it can be spread sexually, so it's considered a sexually transmitted infection. What I want to say is that I have the same passion about C as I started the show with HIV. It is very treatable right now, but you have to know you have it. There's probably 5 million people in this country, and well over 75% of them don't know it. It's a worse hidden epidemic than HIV. So the new CDC guidelines say if you were born between 45 and 65, 1945 and 1965, that's the birth cohort most likely to be living with this. So go get a test. Again, it's a test that's a blood test. It's simple to do. If you have it, then you can get it treated, and you don't have to end up with end-stage liver disease and cirrhosis and ascites.
Okay. Jill, we've got just a minute left. Any take-home messages that you want to leave with our audience?
Yes. Number 1, get tested. Half of these things are, over half of sexually transmitted infections are treatable, and you don't wait to have symptoms to get tested. Get tested, stop spreading diseases, because we have to know we have them to treat them.
Very good. Thank you very much, both of you, for joining us. One from Kansas, one from Texas. What a joy it's been. And now for the answer for tonight's Prairie Doc quiz question, which is true or false. Over 50% of people in the U.S. who have HIV are greater than 50 years of age. True? And the answer is true. We'll be right back after this.
All around town, from stores to playgrounds, babies are on the move. And there are diseases that are on the move too. And some of these spread easily. To best protect him from 14 serious diseases by the time he turns 2 years old, vaccinate him according to the recommended schedule, so he can go on about his business and you can have peace of mind. For more reasons to vaccinate, talk to your child's doctor or go to cdc.gov/vaccines.
A couple of years ago, while making rounds at the hospital, I had a lesson in grace. A young female college student was shadowing along, thinking about medicine as a career, and we stopped in to visit with a beautiful, maybe 88-year-old woman. She was not my patient, but a friend who had been close to my mom for years and was recovering from a bout of pneumonia. The wise elder widow shared with us how she had recently developed a sexual friendship with an older, maybe 90-year-old man. How it was different than what it would have been had he been 30-something, but how they had both so enjoyed a caring, caressing, listening, and naked closeness. It happened maybe 4 weeks in a row after enjoying Sunday brunch together, she told us. And then, last week, he suddenly died. I'm so grateful that it could happen. Being with him in that way was absolutely beautiful, she proclaimed. I think the young college student's mouth dropped to the floor. The elder woman's words were not in the least bit remorseful, and instead were a forthright expression of the celebration of his and her life. My elderly friend also died about a month or two later, and I will never forget how she had taken the time to share her intimate and poignant experience. Of course, everything changes as we age. I didn't say goes away, I said changes. In women, vaginas become smaller, stiffer, thinner, and with less automatic vaginal lubrication. Women can be over-concerned about how her looks are changing. In men, penises become smaller, with less ability to have and keep an erection during sexual intercourse. Men can be over-concerned about erectile prowess. In both cases, self-expectation can become a problem. This is a natural course of aging in all men and women. It's not a question of if, it's a question of when. But these changes can happen sooner than expected as a result of medical problems like diabetes, heart and blood vessel disease, smoking experience, excessive alcohol, or as a result of medicines for pain, anxiety, or depression. Certainly, when something isn't working with one's body, that should bring the individual to consider going to the doctor. It should not bring guilt, shame, or feelings of inadequacy, although those fears and feelings alone can be enough to result in sexual dysfunction. Take a lesson in grace from my 88-year-old friend. Sexual function at any age has everything to do with caring, caressing, listening, and closeness, and not so much all that expectation stuff. We've got about 20 seconds from each of you to talk about a reaction to that story of elderly people enjoying sexual function.
It was beautiful, and I agree wholeheartedly. So it's a very, very nice celebration of life.
Yes. Jill, comment?
Honestly, I'm smiling because it reminded me of the first person I ever diagnosed with a sexually transmitted disease, and that was an 88-year-old gentleman and 3 friends of his. And yeah.
It's tremendous. I sincerely want to thank my fantastic guests tonight, Donna Sweet and Jill Grimes. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota.
Additional funding is provided by
Aberdeen Allergy and Asthma,
Brookings Healthcare,
Dakota Allergy and Asthma,
Dakota Care,
Dakota Dermatology,
the Orthopedic Institute,
Physicians Care, Sanford Clinic Community Service Committee, and Swiftel Communications.
Closed captioning for On Call with the Prairie Doc is provided by a generous support of
Avera
Brookings Health System
and Fishbach Financial Corporation.